Hi friends, welcome back to the channel. This video is entitled Phaco in 12.5 minutes because I've attempted to show you an unedited video, and you'll appreciate that this video is a single take video. You'll often find some videos on the internet that boast of doing Phaco in under 5 minutes. Well, this is not the case for me because I'm not so fast a surgeon. Anyways, this is a case of a diabetic patient with a grade 2 nuclear sclerosis in which we've planned to do Phaco emulsification. Here we're staining the anterior capsule with 0.06% trypan blue, and I'm massaging the anterior corneal surface so that the bubble spreads the dye evenly over the anterior lens surface and we get an even staining of the anterior lens capsule. The most commonly used viscoelastic in the Indian subcontinent is 2% HPMC, and so is the case here. We're refilling the anterior chamber and replacing the dye with 2% HPMC OVD and coating the cornea with the same. Here I'm constructing a 2.8mm triplanar clear corneal incision, and the location is superotemporal as I'm operating the right eye in this particular case. Using a 26 gauge bent cystotome, I'm raising a capsular flap, and I'm going to now proceed with making the capsular rhexis using a Utrada forceps. So you should hold on to the capsular flap near the tearing edge, and in my first grasp I bring the capsular flap around for 4 clock hours. In my second grasp I bring the capsular rhexis flap for about 5 clock hours. In the third grasp I'll move it about 2 clock hours, and in the fourth and final grasp I'll move it about 1 to 1.5 clock hours to give it a circular configuration. We then burp out some viscoelastic from the anterior chamber to create some space because we're going to go ahead with the cortical cleaving hydrodissection, and you'll appreciate that the nucleus comes forward anteriorly, and then we depress the nucleus in the center and bring the fluid wave anteriorly from behind the nucleus and move ahead with the rotation. Dear friends, we all know that diabetics with neuropathy often have abnormally small pupils that fail to dilate normally. One possible cause is neuropathy of the sympathetic innervation of the dilator pupillae. However, the iris of such patients is often damaged with lesions of the smooth muscles and connective tissue and blood vessels. This suggests an alternative explanation of the small pupil, namely that the focal damage or myopathy to the iris limits its motility apart from the neuropathy. Some studies have shown that the pupil in diabetic patients is supersensitive to phenylephrine. This supersensitivity is also found in Horner's syndrome, in which sympathetic denervation has occurred, and it is an evidence in favor of a neuropathic rather than a myopathic etiology in the myotic pupil of diabetes mellitus. So here we are attempting to do a direct chop technique. This is about a grade 2 to 3 nucleus, and as you will see, I'm going to now impale the center of the nucleus with my phaco tip and bring the chopper in from the periphery, from the equatorial or the pre-equatorial region of the nucleus towards the center of the nucleus in the direction of the phaco tip. And once I have a very good hold, I'm going to do a lateral separation maneuver and thus complete a direct horizontal chop. Subsequent chopping and fragmentation of the nucleus is completed in a similar manner. The phaco settings that I'm using are as such. I'm having a 50% phaco power at 350 millimeters of mercury vacuum, at 35 cc per minute aspiration flow rate. This phaco power is pulsed at 35 Hz with a 60% cool time, and the bottle height is at 110 centimeters, and my phaco tip is in a continuous irrigation mode so that there's always some fluid that is entering the anterior chamber, and I do not have a flat or a shallow anterior chamber while performing the surgery. Once the chopping is complete, I prefer to use my Y manipulator, which is a blunt instrument, and I manipulate these fragments of the nucleus with this instrument. So coming back to the topic of supersensitivity of the pupils in diabetic patients to phenylephrine. So it has been hypothesized that this is likely due to an increased activity of the receptors on the smooth muscle surface, although the precise nature of this increase has not yet been established in the smooth muscle. However, there are a number of similarities between a senile meiosis and a diabetic meiosis. Studies have suggested that a reduction of sympathetic activity occurs with age due to a degenerative process, and this process is accelerated in diabetes mellitus, and it is further increased with the duration of the hyperglycemia. But phenylephrine is not without cardiovascular complications. When used in topical drops, phenylephrine is available in either 5% or 10% concentrations because the penetration of phenylephrine into the cornea or through the cornea into the anterior chamber is not so good, and these concentrations are too high to be used as intracameral preparations. In the Western world, preservative-free 1.5% phenylephrine is available for use as an intracameral injection and is often seen to be used in such diabetic patients in which the pupil dilates poorly or used in floppy iris syndromes. But unfortunately, in the Indian subcontinent, or in India for the fact, preservative-free 1.5% phenylephrine is not yet available as a commercial preparation. So more often than not, we have to resort to pupil expansion devices such as the Malugin ring, the P-hex ring, or the use of iris hooks. The obvious problems of phaco in a small pupil is very evident, as you just saw in this video so far. As you can see that the followability of the nuclear fragments reduces. As the iris has come down, the phaco fragments tend to hide behind the iris and are not easy to prolapse from out of the bag. And the other complications that can occur are obviously related to the direct trauma of the iris with the phaco tip. So with this we come to the conclusion of the phacoemulsification process in this particular surgery. Dear friends, it is a common clinical impression that the pupil in patients with diabetic neuropathy is often difficult to dilate, and the agents that are most commonly used are atropinic agents such as homitropin, cyclopentolate, and tropicamide. These agents normally work by paralyzing the parasympathetic constrictor drive, allowing the sympathetic input to dilate and to dominate, and the loss of sympathetic tone in patients with diabetic retinopathy would thus limit the usefulness of the anticholinergic mydriatrix. And that's the reason why we add a directly acting sympathomimetic agent such as phenylephrine in preoperative dilator drops, as we all know that the most commonly used dilator drops in our OPD is a combination of 0.8% tropicamide with 5% phenylephrine. And this makes sense because you know that diabetic patients have pupils which are super sensitive to phenylephrine. So here we're using bimanual irrigation and aspiration for cortex removal, and as you can see that it is a partly blind procedure because the point of engagement of the cortical fibers is obscured by the pupil margin because of a small pupil, and this requires some sort of extra skill or some sort of experience, and you should have done a couple of cases of small pupil phaco to get the idea of how to move your instruments in the anterior chamber and to make sure that you engage only the cortex and not the capsular edge or the capsular bag, because if the aspiration cannula engages the capsular bag, you may cause a dialysis and would require a CTR ring for the IOL implantation. So after pulling out that small bit of epinuclear material from the main incision, I'm keeping the hydration cannula in the side port to inflate the capsular bag and the anterior chamber. I'm waiting for my assistant to load the IOL, and I'm going to demonstrate a hydro-IOL implantation of a single piece acrylic hydrophilic intraocular lens. Hydro-IOL implantation has some very distinct advantages. Firstly, a surgical step is reduced, the step of injecting viscoelastic into the anterior chamber just before IOL implantation. Secondly, it is a well-known fact that HPMC, or any other OVD for that fact, is in itself an etiological factor for toxic anterior segment syndrome. So the hydro-IOL implantation obviates the need for an OVD injection in the last step of cataract surgery and thus prevents the occurrence of toxic anterior segment syndrome. So with this we come to the end of this video, and I hope I was able to impart some knowledge about the pupil characteristics seen in diabetic patients. I hope I didn't bore you with my monologue, and thank you very much for watching this video patiently. If you have any questions, I'll take them in the comments section below. And until then, I'll see you in my next one.